So it's nice to see everyone in the room and also online. This is a different Department of Pediatrics grand rounds, as it's been taken hostage by the Department of Surgery for one day. Today is the Stanley Mercer Research Day, which is our research day for the Department of Surgery. So this is our kickoff presentation. And it's nice to see everyone, and feel free, anyone, to pop in as the day progresses. We'll be right in this location through the day. So I wanted to start with a land acknowledgement that Ottawa is built on the unceded Algonquin-Anishinaabe territory, that the peoples of the Algonquin-Anishinaabe Nation have lived on the territory for millennia, and we honor them and this land. Their culture and presence continue to nurture this land. And CHEO honors all First Nations, Inuit, and Métis peoples for their contribution, past, present, and future. So I will introduce Claudia Malik, who will come up to introduce our guest speaker.
Good morning, everyone. It is my pleasure to introduce today the ground round speaker, Dr. Robertson Harop, clinical professor of surgery at the University of Calgary, and incoming, or just settled the chief of surgery for the Alberta Children's Hospital. Dr. Harop is a pediatric plastic surgeon with over 25 years of clinical and academic experience. He completed his medical degree at Queen's University, surgical training at University of Alberta, and pursued subspecialty fellowships in aesthetics and pediatric plastic surgery with the University of Toronto. He holds a dual master degree in epidemiology and experimental surgery. He has held multiple leadership roles, including Chief of Plastic Surgery, Director of Office of Surgical Research, but also he was our President for the Canadian Society of Plastic Surgeons, and he led through some turbulent times when there were some issues with the breast implants, and successfully navigated that. And he is widely recognized for contributions to surgical education, quality improvement, and cleft and craniofacial care. His clinical and research work has received numerous national awards, including the Plastic Surgery Best Canadian Paper Award and multiple teaching awards. Please join me in welcoming Dr. Rob Harop.
Thanks, Claudia, and JP for having me. That is not going to work. I'll just put it on a little coffee stand. I come to Ottawa every year for the, can people hear me? Can you see me? Yeah. I come every year for the Royal College exams, probably for almost 15 years, but I've never been to CHEO. So it's my first time, so thank you again for having me. I also had a land acknowledgement. So I guess I don't need to do that again. But I found this, I stole this from the archives at the National Gallery. And it's, this Algonquin family is camped, I'm assuming, on the Gatineau side of the river. And that's the, I guess, soon-to-be Rideau Canal system. And then I found this other picture that's sort of the same picture now. My objectives for the session today, and I apologize to the non-surgeons for the slightly surgical slant here, but I do think many of the principles that I'm going to talk about apply to all of medicine. So I was hoping to allow you to answer for yourself the following questions. Does QI apply to me in my practice in any way? What does a QI project look like? What benefits might, and I said my people, and my people, as you'll see, can include a bunch of people. It can include your colleagues, it can include yourself, making your life better, and it can, of course, include your patients and maybe their families to make their lives better. And then I also wanted to make reference to what I call the loyalty programs associated with QI and the way that you can collect bonus points with these loyalty programs. So we'll get to that. And then I did include a couple of sub-questions for the residents, and that is, what is a control chart? And what is a PDSA cycle? And then we'll come back to those and why it might be relevant to you as a resident. My disclosures are, I actually have no training in quality improvement. It's all on-the-job training. And I am, as Claudia said, the director of, in Calgary, what's called the Office of Surgical Quality. It sort of sounds like a customer loyalty thing, but it's our group of people that are interested in quality improvement in Calgary for the Calgary zone for the Department of Surgery, which includes about, I think, 350 or 400 surgeons, most of whom don't actually have any knowledge of quality improvement. So one of our missions is to try to spread the word amongst the department members. If you're like me, you probably find that you are inundated with references in your life to quality improvement. The American College, for any of you who are members, has whole bulletins in the plastic package that comes every month or so that it talks about quality. They have a quality improvement seminar session every year at the national meeting. Our national societies are interested in quality improvement. The College of Physicians and Surgeons, and this would be relevant to non-surgeons as well, it seems that every college has a requirement now for us to be doing quality improvement work of some sort. I, in preparation for a previous talk, kind of went province by province because I thought it was just Alberta that had this requirement, but it turns out all the provinces have this requirement. And finally, and I'm probably missing all sorts of other groups, but the Royal College explicitly refers to quality improvement as a standard that it wants us to live up to in some way. This maybe is for the residents. So when I looked at the various leafs of the CanMeds framework, quality improvement is referenced in 3 of the domains and maybe even more. But for example, in the expert domain, we're supposed to be actively contributing as individuals or members of a team to provide continuous improvement of healthcare quality for our patients and safety. In the scholar domain, we are supposed to apply the science of quality improvement to contribute to improving systems of patient care. And lower down, we're supposed to implement processes to ensure personal practice, our own practice improvement. And then it shows up again in the leader domain. We must again apply science of quality improvement to contribute to improving systems of care. So it is a priority for the Royal College and for the CanMeds framework. And so for residents, when I mentioned the question, does QI apply to me in any way? And I call this a resident alert. When you see key competencies in the Royal College CanMeds framework, especially if they come up more than once, it often means that you may see questions about this topic on certain exams that you have to write at the end of your training. So I think that residents should start looking for opportunities to understand QI for that reason, if it's only for that reason. As I mentioned, the College of Physicians and Surgeons of Ontario and Alberta require that we are involved in quality improvement projects every 5 years in a cycle. I would say they're not very explicit in how you're supposed to do those projects, but they have references to modules. So it is an opportunity to learn about quality improvement in the course of maintaining your professional certification. For those of you who are academics, it's quite possible that you are in the course of your research involved in some quality improvement projects and maybe don't realize it, and maybe the Venn diagram here is quite far apart, but it also may be very close together in many cases. And I'm going to highlight an example of what we started as a research project in our little Division of Plastic Surgery at our children's hospital that turned into, and we didn't know in the beginning, but it turned into a very good quality improvement project. I thought I had removed all the little bells, but I was going to have these little bullet moments. So as just a random surgeon or pediatrician, how does quality improvement apply to me? The answers that I think are relevant are we're being asked to do some of this work as a part of our accreditation. As residents, we may be asked questions on our Royal College exams. And finally, we might be doing this work already, and I bet you many of you are doing some of this work already. So resident alert, you might see some of these quality improvement questions on your exam. The Office of Surgical Quality, which I mentioned is the QI section for the Department of Surgery in Calgary, which is 400 surgeons, is really this mom and pop organization that consists of myself, Andy Graham, who's a thoracic surgeon, and like me, Andy had epidemiology training but no QI training. And then we have a consultant, Francisco, who's very energetic and is formally trained in QI, and Jennifer, who is our analyst who helps us dig into data to try to help facilitate the various projects that are going on in the department. The things that we do include, we oversee, every section is supposed to have a QI group within it. Some are more successful than others, so we oversee and help them, I guess. We have what we call our Quality Council, which is really kind of a seminar series where every month we talk about either a methodology topic, or we highlight projects that are going on, or we bring in visiting speakers. We support any project within the Department of Surgery as much as people want. Some people ask for more help than others. Francisco keeps a giant database of information, resources, on a share drive within the Department of Surgery. We sort of suspect that most people don't know anything about it, so we try to plug it all the time. We have formal analytics support, so for people that have a good project but they have no idea how to access the data, we have Jennifer and her people that can help people find the data. And then finally we have a training program for the residents as part of their half day. So for the foundations residents, the first 2 years of surgery are kind of general years. We have a basic QI course that we give, and then we go around to each of the sections over a 3-year cycle, and we do either a 2 or a 3 half-day session on quality improvement. And we want them to bring a project to the event so that we help them work through the project and hopefully turn it into a real project that comes to completion. So my own journey into quality improvement, I think, was accidental. This is myself and on the other side, Tom Cawthorne, who was at the time one of our residents, and this is on a mission. We would go to either Vietnam or Peru every year. And when Tom came with us as a final year resident, he observed afterwards, or even during, I think, that the cleft kids that we were operating on, they all went home. We kept them overnight, less than 24 hours. Usually they would stay for 12 hours. And then we sent them home out on their own with no pain medicine except like one little package of Tylenol. And they did fine. And Tom said to us, well, they seem to be doing like as well as our own patients at home, with way fewer resources and without the need for a long hospital stay, and amongst other things, a lot of narcotics. And so Tom wanted to do a project, and Frankie and I, that's my other senior colleague there, at first we didn't quite get it, but Tom started asking us for lists of our patients. And then in the process, Tom then became a fellow at Sick Kids. And during his time as a fellow at Sick Kids, he also did a QI ticket through the University of Toronto. And so he turned this into his project. And and has continued, as you'll see, we've continued to expand this project to other populations in our cleft palate clinic over the years since then. So this really was the beginning of my awareness of quality improvement, and also is the example that I was going to use to highlight the principles. It's beeping at me. Do I need to do anything? I wonder if it means it. Oh, it's good. Solved. I just had to move my hand. Um, so, as a general framework, there's lots of frameworks for quality improvement, but for me, this one is easy to understand. And this is the one that often people get asked questions about. So this one's called the Model for Improvement. And what it does is it breaks down a QI project into several simple steps. The details of the steps can get very, very complicated, and that's why it's helpful to have a QI consultant if you're doing a real quality improvement project. But the principles are sort of simple. So to start with, you need to understand what your problem is and what part of that problem you're trying to solve. So this dog must have fleas or something behind its ears and is scratching. And it's kind of bugging you because it's keeping you up all night because the dog's scratching. So you need to deal with that particular problem. But the next step is you need to be able to measure something about the problem so that you know you're making a change. So in this case, it's the number of times the dog scratches per hour. And then you need to move on to make a change. So the vet recommends product XYZ, and you use that to try to deal with the problem. And then finally, you move into what's called the PDSA cycle, Plan, Do, Study, Act. So you introduce the intervention, and you measure the scratches per hour. And if it's not working, you go through the cycle again with the Miracle shampoo to see whether you can solve the problem. Miracle shampoo might not work either, so you have to move on to maybe the next thing. So for the residents, the resident alert, what is a PDSA cycle? It stands for Plan, Do, Study, Act. That sounds like a very good multiple choice question to me. So in our case, with our cleft project, so we had these cleft kids that were staying too long in the hospital. So we need to reduce our length of stay after cleft palate repair. So babies with cleft palates, we operate on roughly at a year of age. We need to do that because our hospital resources are strained, and this was right around the time of the pandemic as well, and things were seriously strained. We were also realized, because we had, all of us had trained in other centers, that to some degree we were out of line with what other sites were doing. And as well, Tom had the sense that part of the reason that the patients were staying for so long was that we were giving them too many narcotics. So that was our aim. We needed to try to, in particular, reduce our length of stay, but as a secondary outcome, we wanted to reduce the narcotic consumption or administration to these babies. So my next bullet point is that in many cases, QI could be, your project could be and should be possibly a grassroots project that is related to some irritant that you have in the course of your clinical life. And everybody has different irritants, but this is one very practical way of solving those irritants. And it's also supposed to be done in a local context. So in other words, you don't need to make this a big, big picture like save the country or save the world project, but it's mostly about your local context and solving a local problem. Okay, so the next thing was, what are we going to measure in our project? Because we need to know that we're making a change. So we decided to look backwards at 40 patients, which was pretty easy because there's 2 or 3 clefts a week. So it's not hard to come up with 40 patients, and then look forward with our 40 patients with our plan, which I'll get to in a minute. We're also going to, so we're going to measure length of stay, but we're also going to measure their opioid consumption and also the oral intake over the first 24 hours. So those are the things that we were wanting to measure. So then what are we going to do? How are we going to make a change that results in improvement? We decided And I would say Tom decided, and he told the rest of us, that his plan was we were going to introduce a clinical care pathway for these patients. And that is sort of sounds simple, but it's kind of complicated when you think of the journey of a cleft palate baby from their visits to the clinic to their discharge from hospital. So the first thing that we did is we tracked all of the steps along the way. So visit to the cleft palate clinic, decision to have surgery, discussion of the surgery, the booking of the case, etc. Oh, the order of the case in the day, assessment by anesthesia pre-op, where they get placed in the hospital, and there were many places they could get placed. The type of anesthetic, the type of local anesthesia that we used, the type of repair that we did, and then the post-op care of them. Where did they go post-op? What did we do for management? And finally, discharge from the hospital. So it's a bit of a complicated process. And then, as you can imagine, there's many, many people that touch the patient along the way. So we had to get the stakeholders involved, and the people that we could think of included the surgeons, the anesthesiologists, our cleft palate clinic nurse clinicians in the clinic, families, so patients obviously they don't have anything to say about this, but their parents did, pediatricians who work with us in the clinic, the administration of the hospital, because we were suspecting that maybe we needed to make a change in terms of where the patients were going to go, pharmacy, dietitian, so all of those people. And then we did what's called a fishbone analysis or a Ishikara analysis, looking at the barriers to care, and in this case, the barriers to expedient discharge from the hospital. And the details are not that important, but basically we broke it up into the different domains. So the environment, the IT, in this case, we were just getting Epic at the time. So we had an old system, but Epic had just arrived with, as you probably know, very poor support. So, it was a big learning curve for all of us. All of the people who were involved, and then the various steps along the way, getting the surgeons to agree on things, which, as for non-surgeons, that can be very, very challenging to get all surgeons in your group to agree on a certain way of doing things. However, I would say that process, it does align with I would say our natural tendency as surgeons to be collaborating with other people, thinking of new ways of doing things and problem solving, and also lateral thinking, like thinking of doing things in a different way. So what did we do? So this is the pathway. And we broke it down into the pre-op steps, the intra-op steps, post-op, and then discharge home. Pre-op seems like it should be kind of a non-issue, but I would say parents and patients, they often, their behavior when they're in the hospital will relate to what they were told the expected process would be. So if they're all told they're going to stay 2 or 3 nights, which is kind of what we used to say to them, they all think they're going to stay 2 or 3 nights. And so if they go home the next day, they think, like, I guess some of them think, oh, this is great, but most of them think that you're kind of cutting corners or doing something in a way you're not supposed to. So we had to change their expectations by telling them that they were all going to go home. We said, most likely you'll go home the next day, but we're not promising, and there's a chance you might have to stay longer. So we changed that expectation. We made sure they were the first case of the day, because in post-op stay accounting, it's the number of hours that you stay in the hospital. It's not necessarily the days. Like, hours is more granular, because if you get rid of somebody an hour earlier, you can put a new somebody in that patient's place. We gave them some Tylenol pre-op, so our anesthesia colleagues had input into this. We changed our intraoperative approach, so the anesthesiologists were going to do maxillary nerve blocks, which is a type of block that blocks sensation to the palate. They were going to give them a certain type of general anesthetic, and we were going to use local anesthesia in a very standardized way. And then post-op, Believe it or not, we used to put them on morphine drips just because that's what we always did. We stopped doing that. We put them on regular Tylenol Advil, and we give them morphine-only PRN. And then we, as I say, tell them that most likely they're going home the next day. So of the things that we used to do that we don't do anymore, we used to have no standardization, and that meant they also went patient units all over the hospital. We had no regional anesthesia in terms of the maxillary nerve blocks. We all did our version of local anesthesia. We gave almost all of them morphine infusions. We didn't give them NSAIDs because we were concerned about bleeding from the palate. And we gave them PRN, other analgesia aside from the morphine post-op. Afterwards, we had the standardized pre-op discussion about how long we expect they're going to stay. We send all of them to our short stay unit. So we also call it our day surgery unit, but it's day surgery in the sense that they can also stay a day and a half. Like they can stay one extra night. I used to think that the patients were getting ripped off if they went there because it's sort of a Spartan unit. You're sharing a room with other patients versus our inpatient unit where there's windows and a nice bed for the patients to stay. But what I've come to realize is that the nurses now in our day surgery unit, our short stay unit, are so facile with these patients now that I believe they get better care there. And I'm actually unhappy now if for some reason there's a need because of too many patients in short stay for the patient to be admitted to an inpatient bed. So I've come full circle on that one. Morphine infusion, we stopped doing that afterwards. So NSAIDs are now given right away, scheduled Tylenol, Advil, and just oral morphine PRN. I would say this is another bullet point, is that QI initiatives often have buy-in from administration because there's something in it for them, especially if you include them in the discussion beforehand. And maybe Claudia will be able to comment on your local experience with that. But I've personally been very, very pleasantly surprised that operations people are totally on board with QI initiatives. We had to do a little mini PDSA cycle here with, trying to use the pointer, there it is, with our maxillary nerve blocks. There were 2 champions for the maxillary nerve blocks amongst our anesthesiologists, but the others were unfamiliar with it. And so in the first little PDSA cycle, we had to have a process where we tried having a system in place where if it was not one of those 2 anesthesiologists, one of them would come to the room and help give the block and train the anesthesiologist. So they're now all very good with it, and we have no need for the trainers to come in anymore. I learned how to use a laminator, and this is the kind of care pathway that we have attached to our plastics cart in the room so that the residents who come through and cycle through, so they're not necessarily familiar with this, but it has the checklist on it for everything that we're going to do. So much like we use our checklist for every single surgery, we use this checklist for our cleft surgery. So it's a additional checklist, but it keeps everybody on track. So then we, as I say, we looked at 40 patients backwards, and then we looked at 40 patients forwards. We looked at their opioid consumption, their oral intake, and their length of stay in hospital. And what we found was, so with respect to narcotic consumption, before the pathway, the babies were consuming 700 micrograms per kilogram during their stay. In the first 24 hours, they would drink 171 ml of fluids, and they stayed for 2.4 days. Claudia's looking at me and shaking her head because that's really bad for clefts, but that's where we were at. Yeah. We dropped the morphine consumption tenfold, and we increased their oral intake roughly by double, and we reduced our length of stay to a day and a half. So that's when they arrive in the hospital. They usually go home at about noon the next day. So as part of my QI journey, at first when we first looked at this is the way we looked at it. We looked, in this case, at opioid consumption. So it dropped by tenfold, and you sort of think, okay, that's probably significant. It makes sense. We looked at length of stay, pre and post, probably significant, and used the typical t-test for that. But then Tom was in the middle of his QI training, and he came back to us and said, I learned something. And so what he said was, this is old. Like, this is the old way of doing things. This is not the way we do things in QI, because it doesn't tell you anything about how you went from here to here. You're pretty sure something significant happened between, is that moving? Yeah, here and here, but you don't really know what happened. So what he said is what we need to do is add the play of time, which in this case, so there he is, Connor McDavid there. That's his pre, and we saw his post. So with the play of time, you realize that things happen between then. My circle is not following. So there's a lot more information when you add the play of time. So that introduces the so-called control chart. And in QI work, the control chart is kind of the main outcome that you're looking for in terms of results. And so the control chart, and for the residents, this is another alert. What is a control chart? This is a control chart. So the control chart includes all of the consecutive patients plotted over time. So it does add the play of time. So it's a dynamic approach to analysis as opposed to a sort of digital approach like before and after. There's a center line that represents either the mean or the median. It's usually the mean. That's the line in the middle. And there is an upper control limit or an upper confidence limit, which is the mean plus 3 standard deviations, and then a lower confidence limit, which is mean minus 3 standard deviations. So in a way, if you think about it, it's like taking the normal distribution curve and turning it sideways to look at each of those dots to see where they sit relative to the central tendency or the mean. The system is then designed to separate signal from noise. So in standard hypothesis testing, the noise represents random variation, something that's within the normal distribution. So it's also called common cause variation in QI work. The signal is like true variation. So my example that I used here is the noise is I drive to work every day. I take the same way to work every single day. Sometimes I'm a little bit later, sometimes a little bit earlier because I don't hit the traffic lights exactly right or whatever. Whereas signal would be when they rebuilt the bridge over the river and they narrowed all these lanes down into one lane, all of a sudden I had to budget another 20 minutes to get to work. So that was true variation. That wasn't just random, it was actual true variation. So in QI, we're trying to introduce interventions that aim to target special cause variation. So you can separate the signal from the noise in a couple of different ways. And actually, there's probably many, many different ways, but the simple ones are you can look for outliers. So patients or dots, but in this case, it's patients that are outside of the 3 standard deviations. So those would be usually not random variation. There's something different about those. As well, you can look for trends. So it turns out if you see 8 consecutive points that are above or below that central tendency, that is considered to be significant in QI world. So what happened here? Here's our length of stay patients. We had our 40 patients here, and then all of a sudden we had our other next 40 patients. So the difference here is that we introduced the pathway. So the pathway was introduced, and every patient afterwards went through the pathway, and something happened. The central tendency dropped, and as well the variation tightened up a little bit too. So the upper and lower control limits got closer together. Our opioid consumption also dropped dramatically, and likewise the the spread, the variation tightened up significantly as well. So it was the introduction of the pathway. And to our surprise, Frankie's and mine, Tom was not at all surprised because he pointed out our patients in Peru got no narcotics at all. But 43% of our patients needed 0 narcotics. Okay, what about the oral intake? I said that it doubled in the first 24 hours, but here's where the control chart actually probably tells you more information. So yes, there are central tendency, the mean went up and almost doubled, but we were all over the map still in terms of our oral intake. So we probably had more room for improvement in terms of how we manage oral intake in these babies afterwards. Okay, sustainability. This is a term that is used in QI. So we did the 40 patients before, we did the 40 patients afterwards, but what happens beyond that? Because sometimes people lose interest and maybe you drift back to your previous state. So then we looked at the next 75 patients and used the control chart. And in terms of length of stay, it pretty much stayed the same. There's still some outliers here. So we actually did go and look at these outliers, and it turns out they were kind of clustered around weather patterns in Alberta. Southern Alberta is we can get 4 seasons sometimes in one day. But sometimes you'll get a giant winter storm and it kind of shuts everything down, and many of the patients live a long, long ways away. It turns out that almost all of these patients were staying because of weather-related incidents, and they couldn't go home. The opioid consumption, also, we actually got better and better and better, and now I'd say most of our patients take 1 dose of narcotics afterwards, so that was a significant improvement for us. The other thing that we can look at is the outliers in this case as reasons for trying to understand what went wrong, what happened here. It turns out in that sustainability part of the project, we didn't really have any outliers, but if we did, we would probably go back and look at them. So we're almost moving now from sustainability to quality assurance. In other words, now this is the way we do things. So if there are outliers, it means that something went wrong or something didn't, maybe not go wrong, but something didn't quite go right. So that in quality assurance, you're looking at, are we doing what we're supposed to be doing, as opposed to quality improvement, where we're trying to reach a new state of care. So better care for your patients. Really, this is talking about the sustainability thing. I put this slide in because every place, I think, has its own model for QI. Like that model that I showed you, I think is one that's simple. It turns out in Alberta, our provincial health authority likes us to use a slightly different model. They all reach the same goal. And I guess people might ask, why would you even use a QI model like this that seems kind of complicated? And I suppose the answer is, in a real QI project, if you don't use some sort of formal approach, there's a good chance that it'll just fall off the tracks and get derailed, and you may not achieve anything with a whole bunch of work. So anyhow, they refer to this as the A3 chart. It has all the various tools along the way. You need a consultant to navigate your way through this, but it is the formal process of QI that's used where we are. I would say most places have QI experience and expertise available. You probably don't even know it, but there's QI consultants at every site in our city, and they're often really excited about any project that you have. We've expanded this project to other parts of the cleft lip and palate journey. So babies come to us the first week of life and we see them till they're adults, and along the way they have a whole bunch of different procedures, and so we've expanded it to the other procedures. And something that we've noticed is that it's the process that it took to do the first pathway and study the first pathway was quite long. That was for the cleft palate kids. Then for the next group of kids, alveolar bone graft kids, they're older cleft kids that need to have bone put into their gum cleft. We introduced a similar pathway, but we were able to shrink the time that it took to implement and study the pathway. And now we're doing it for the babies that have funny shaped heads that need cranial vault remodeling. So you can get some efficiency as you build out your projects over time, especially if they're related to a single program. To some degree, we thought that we might be able to exploit or get back at Epic, like take advantage of all the data that Epic contains. It turns out it's not as easy as we thought, and you actually need people with expertise in the data management to actually get data out of Epic. I'm hoping, and maybe you guys are better at it than we are, but it's been very difficult for us to get data out of the MR. I would say that as far as where does QI fit into an academic practice, I think it's related. So if research is studying the gaps in knowledge and how do we study the system to understand and solve a particular problem in a general sense, that's research. Whereas quality improvement is how do we make things better in our local level. It could be generalized, and some of our projects have been used in other centers. And then innovation is like totally thinking laterally. So if you're an academic investigator in surgery or pediatrics, these things are all related to one another. I guess the question sometimes comes up, I had this question, like what is the difference between QI and research? In general, I said here, research is hypothesis testing. We all know that. Whereas QI is really reaching a new level of performance, but it does not necessarily involve hypothesis testing. You use a very controlled environment when you're doing a research study. You don't want to have that much variation going on that you can't understand, so it needs to be a kind of a closed system. Whereas QI is a more of an open system that is happening in real time. In research, you use hypothesis testing, different types of analysis that you're familiar with, and in QI, you tend to use these other tools that are a little more foreign to us, like the model for improvement that I showed you. Lean, you might have heard of. Statistics are more important in research, whereas the clinical changes are more important in quality improvement. Sometimes there's overlap. One of the things about QI is that often your research ethics boards don't require the same degree of testing. So for us, we send them a note about it if we have a trainee involved, or we're thinking we're going to publish it. So we do actually apply for ethics approval, but it's an expedited process that happens very, very quickly. I included this slide just in my mind. I think about this when I'm thinking about the difference between research and quality improvement. Research involves a very, very controlled environment. So it's a lake, this placid lake where there's like very little coming in and going out. And so the movement of the boats around the lake can be studied very, very, in a very granular way, whereas QI is more like the river. So it's just the boats that are coming along. You're sort of studying them as they come along. For academics, you might find that QI is a teeny part of your overall practice, but I would say one very, very valuable thing that we have coached our academics on is that trying to actually bring all these things closer together. I think if you're going to be a successful academic surgeon or pediatrician, having your research interest align with your clinical practice is very, very helpful. And then there's this bonus if you also include QI, because you're making the journey better for your patients, those patients that you have a clinical interest in. So you could have synergy with your clinical and research interests. JP, can I just ask what time I have here? Just
15 minutes.
15, okay. I might just then close with this other version of sustainability. Sometimes, often, when you're talking to people about QI, their eyes kind of glaze over and it seems foreign, it doesn't seem that interesting. One thing that has produced enthusiasm amongst our members has to do with another version of sustainability, and it's the sustainability that people in my generation are not as used to, but the younger generation is very, very concerned about the impact that clinical medicine has on the environment. And so recently, the sustainability group in Calgary came to us in QI and has asked for us to become involved with their initiatives. And young people are very, very keen on this. So one of the this is an adult project, but it's one that we worked on with through the Office of Surgical Quality. The fellow in thoracic surgery was concerned about the waste that was happening with the trays that they had to use for their cases. They all came with these giant trays that had 2 tables to put them on. And for their video-assisted thoracoscopy surgery cases, they hardly used any of the equipment. And so he did a project where he worked with the nurses, the surgeons, to try to produce a shrunken down tray, and then he tried to study the impact of it. So he basically reduced the tray from like all of these to a teeny little one, and when he counted the instruments, it was less than half, which doesn't seem like much, but they were able to, here's this picture, this is this big kind of square thing goes in the autoclave and gets processed, and it has to be filled with all these 6 trays. Now he's got it down to these 2 trays, so there's 2 more shelves that are available, and when he did the math, he was saving almost $11,000 with his initiative in terms of the processing costs and the repackaging costs. And then he calculated the environmental impact, and this is kind of complicated, but he dumbed it down and said it was a year of savings from his initiative was equivalent to what it cost to or what is emitted by a household in Calgary, or what is emitted in terms of a car trip from Calgary to Montreal. So these things are very, very important to lots of people. This is now a medical student that came to us in plastic surgery at the Children's Hospital with a similar idea where she wants to shrink down our pack that we use in the operating room. And Claudia showed me one that they use in their little minor surgery room upstairs. But again, in plastic surgery at the Children's Hospital, we get these huge trays with all sorts of things that we just throw away. So this medical student has come up with this project where we're going to shrink it down after a consensus with the surgeons and then study the impact on the environment and cost. So my point is that these things are very, very important to people, and they're useful in getting people excited and interested in quality improvement. So it could be synergy with your clinical interest, but with your personal values in this case. Finally, the loyalty programs that I referred to, everybody has to do the QI projects in each of their provinces. In Ontario, you have to do the individual ones, but you can also be involved in the group projects as well, where your team works together. So in our case, with our cleft projects, this would count as a group project because we've all been involved with it. And then the bonus programs that I referred to, the Royal College has revamped the various sections of our maintenance of certification, and now Section 3 has a heavy emphasis on quality improvement. And so you can use the same projects that you're using for your provincial requirements for your Royal College requirements as well. And these tend to be the ones that are hard to get, and also you get a lot of points for the equivalent amount of work to the other sections. So I think I will wrap it up there and leave time for some questions. These are the bullet points that I was hoping to highlight relative to quality improvement, and I'm happy to take questions or advice, for that matter, from Claudia.
Question? Let's see if we have anything.
Oh, yeah. I probably have to look. Oh. Did I cut them off? Chat. The first question, we will begin in a few minutes.
Dr. Nasser has a question, and Dr. Yin.
Well, thank you so much for the presentation. Thank you for explaining that the whole team confused between QI and research. And one of the table received dissemination. Like, would you, your great work in cut ballot, would you, what will happen if you disseminate it? What would you publish? Like, why not? Right.
So the question has to do with, again, the distinction between quality improvement and research. And I guess, can you publish your work in quality improvement? And I would say, first of all, yes, you can publish your work in quality improvement. The journals often, at least if it's your clinical journal for your specialty, for example, I would say they often don't get it at first. They don't understand when you show them a control chart what that is. And they actually want the other version of the outcome, and that is the two bar graphs side by side. But more and more they're becoming interested in it. It sometimes requires a supplementary letter, like maybe you'll get a rejection first and you send a supplementary letter explaining and maybe asking for somebody who has expertise in quality improvement to review the paper for you. That can be helpful. And sometimes they actually would take them as a paper that is of, well, it's of clinical value, but it's also of educational value. So it's a type of publication that you could send in as a special topic where you're actually educating the readership on the process, and using a real tangible example can be helpful. But in many cases, your research actually may be quality improvement. If you're going to try to publish it, you should get formal ethics approval if you think you're going to publish it. And as I said, whenever we include a trainee on a project, because they're part of the medical school, we always ask them to submit an ethics application as well.
What we have here at CHEO, we have now a QI committee that in the past worked a lot with REB. And what happens is that the QI committee has done a form in REDCap. If you think is deemed for QI, is going up on that. We are 3 or 4 in the QI committee. It's reviewed and then we give feedback for them. If we deem that is a QI, then a letter is issued saying that this is a true QI. So we took off the workload from the REB, but if we're not sure, it goes back to REB.
Yeah.
Yvonne?
Yvonne?
Of these kind of care pathways or QI initiatives, we do like a bundle of changes at a time.
Yeah.
And how do you go back to look at what parts of the bundle are actually helpful? Because are you actually doing things that are not beneficial, that could actually be, you know, you could probably save more time. I'm thinking like for example, the maxillary blocks, how much extra OR time is used, is that measured? And is that a significant improvement in the change in the outcome? So how do you separate them? And is that part of the kind of feedback portion?
So Yvonne Ying's question had to do with care pathways as a bundle of changes, and how do you separate the impact of individual components of the pathway and determine whether they're significant or not. Yeah, with pathways, it is hard to do that. I would say the ones that you think are going to be well, either high impact or high resistance, then it is probably worth doing a little mini PDSA cycle on that. So the maxillary nerve blocks is a good example. We had 2 champions. So these are blocks that require ultrasound guidance. So they're a little bit more complicated, a little bit more difficult than just a typical block where you put the needle into hopefully the right place and you think you're pretty good. This is a little bit more challenging. You have to get into a tight spot, so they need ultrasound guidance. We had 2 champions who had seen this done in other centers where they were at. They were very interested in this, and they were prepared to do a little, I don't know, dog and pony show to teach the other anesthesiologists about it. And I would say our anesthesiologists all got excited about it. They felt empowered. They do a different version of the block a different block for the alveolar bone graft kids where we're taking bone from the iliac crest. They got very excited about it. They have an RT who comes in with the ultrasound machine. They get to use the ultrasound machine, get some better experience with that. So they were on board. BC Children's Hospital wanted to use the pathway as well, and when they took it to their people, the subset of their people, the anesthesiologists said, no, we don't want to do this. We're not interested. Only 2 of them were interested, so it didn't actually work for them. But that's where I say the local context in quality improvement is really, really important. For us, it adds 5 minutes. That's about it. And it actually brings the team together on time to show up to start to do this. So it was beneficial to us. But I get it. In BC Children's, their anesthesiologists are a lot more subspecialized. So people kind of come into the room that they've only done 1 cleft in the past year. So they could not make it work. So their pathway, which is now similar to this one, it works for them, but they don't include the blocks. There's a couple of...
The other things what you can do is that if you arrive in sustainability phase, you can start playing with 1 element at a time. And if you can see that it's going off out of 3 standard deviations, then you know that it's better to put it back in.
Michelle has a question.
Yeah. Oh, it's her hand is up and she's going to speak, I think. Yeah. Yes, Michelle. I think you might be mute. Oh, now she's here.
Hi, thank you so much for highlighting this topic so clearly. I'm a pediatrician and I also work with the CPSO quality department, both on the QA and on the QI side. And I hope it's okay. I just wanted to highlight in 10 seconds a change that's coming so everybody is aware of it. So you're correct that there are quality improvement obligations for everybody. It's on a 5-year cycle. In the past, if you've done it individually, you had to do chart reviews and a number of other things. There's a 2.0 version coming in 2026, which will be easier for everyone to complete. And those of you who do it with the hospital, really, the requirement is just going to be doing some modules that will take no more than an hour and an awareness and involvement in the hospital QI project. So that's the piece I think sometimes people are not quite aware of, the piece of the project that they say they may be involved with at the hospital level. And they are all reviewed, and I work as a QI coach for those who need some coaching with their quality improvement projects. But if you can just do the basic requirements, then you will meet the standards for 5 years. So watch for something new and easier coming in 2026. Thanks so much for letting me let people know.
And Michelle, is there is a place for people to document their work with the CPSO?
Yes. So there, through the CPSO portal, there is a specific quality document that needs to be completed on a 5-year cycle that does get reviewed. And the CPSO is really moving away from practice assessments to QI and allowing and encouraging the members to show that they are doing continuous improvements in their practice and fewer of those practice assessments, although I work on both sides and still do practice assessments as well as the QI coaching.
And JP, do I have time to ask Michelle another question? My question was, so I guess it was a comment. In Alberta, we have to do 3 projects. One is a QI project in your practice or in your group. The second is a QA project related to standards of practice, so the college's standards of practice. And the third is a personal improvement project, which can be challenging because that really involves coaching, getting coaching, and you have to go and seek the coaching. So I guess my question was not really a question, it was more of a comment, but does that sound similar to what's happening here?
It sounds a little bit different, but it sounds similar to those people who do it individually. So if you're in an individual practice in the community and not doing it as part of a group, there are 3 exercises that you go through. One is an assessment of your own practice and charts. One is having a peer review some pieces of your practice for you. And the other is looking at some data-driven elements, pulling data from your own practice, and out of that, developing developing two practice improvement plans. One has to be patient related and the other can be related to personal improvement. On a hospital, if you do it as part of the group, though, it is more of a streamlined process of completing modules to make sure that you understand what the standards are, what your risks are, and how to mitigate them, which is a bit more QA related, and then awareness and involvement in your group or hospital's QI project.
And is this coming from, like, when I surveyed across the country, every province that I could find has something similar. Do you know where it's, is it coming from somewhere, anywhere?
Great question. I don't know the answer to that either.
Snowball effect. Okay. JP is, I think, saying we should move on. Yeah. Okay. Oh, one more question.
QI goes hand by hand with some sort of short continuity of care.
I'm not sure I understand that one.
So it's when you're looking at trying, that what I understand is in trying to improve the care is QI part of it, goes hand in hand with.
Yes, I would say that is ideal, as if your QI project goes hand in hand with better care. Yeah.
Any other questions?
Well, thank you very much. Thank you for inviting me to Ottawa as well.
We'll take a 5-minute short break, and then we'll get going at 9:40. Thank you so much. That was great.
Yeah, thanks, JP.
Yeah, no, rest. It was really clear, and it's as